With your permission, shall I start the session?
Yes, please.
Thank you so much. A very good evening to all of you present on today's session. I am Nishita from ClearNet. Welcome all of you on Academy of Paediatrics Gujarat e-Gurukul PG Clinic. ClearNet is proud to be associated as a digital partner. Now I'm going to play a very short ClearNet's video. I would like to request all of you, please have a look. Thank you so much everyone for patience watching. ClearNet is India's largest live digital CME platform for the doctors. Now I would like to hand over the session to Dr. Nehal Patel ma'am. Ma'am, over to you. Please proceed with the scientific lecture.
Thank you all. PG Clinic and e-Gurukul is a flagship honor of the AOP Gujarat. And I thank Dr. Rakesh Desai, President AOP Gujarat, and Dr. Kirit Sisodia, who is Honorable Secretary of the AOP Gujarat, for their continuous support for this e-Gurukul program. I invite Dr. Yogesh Parikh sir, who is project in charge, to say a few words. Sir, please.
Thank you, madam. We welcome all the participants and faculty on behalf of AOP Gujarat, our President Dr. Rakesh Desai and Dr. Kirit Sisodia, and our project in the coordinator Dr. Nehal Patel madam and Dr. Prashant Karia. So, and our expert faculty Dr. Baldev Prajapati sir. Without him, this e-Gurukul project is very much
Non-existent.
Popular because of Dr. Baldev Prajapati sir only, and we invite different expert faculty from the various zones, and it is like a teaching program along with the like exam pattern. So we welcome here, and our Dr. Yesha Patel, congratulations to Yesha. At the last moment, she has agreed to be presenter in from our medical college, Government Medical College Surat. So, and our Dr. Upendra Chaudhary is a mentor. So, thank you everyone, and we learn today's session for the pediatric neurology. Thank you. Over to you, madam.
Thank you, sir. So today is the discussion on pediatric neurology, and we have an eminent pediatric neurologist with us, Dr. Harshruti Shah. She is a senior child neurologist and practicing at Rajvi Children Hospital, Child Neuro Hospital at Ahmedabad. She is ex-assistant professor at BJMC Ahmedabad, and she is ex-professor of SBKS Medical College, Vagodia. She has received so many gold prize at Taiwan. She has Young Investigator Award of Japan. There is so much in her list that I cannot complete in a few minutes. So she is the one most thing I liked about her is her efforts are always tireless, and she is as much as in practice as as much in the knowledge sharing and teaching also. She has the Times Power Woman Award winner of 2021, and she is at present Secretary of Child Neurology Group, Gujarat. Welcome, ma'am. We are really privileged to have you. And we have our own Dr. Baldev Prajapati sir, who is guiding every PG clinic and many other Gurukul type of clinic at different days in the week. And sir never get tired teaching the students. So welcome, sir. Over to you and Yesha.
Good evening, friends. Welcome these experts. As Dr. Nehal introduced, Dr. Harshruti Shah, our own person, and very eminent in the field of the pediatric neurology. I'm sure that her presence will add more when we are discussing on specific aspects of the case, whatever Dr. Yesha has selected. And of course, Dr. Upendra is also there with us. to add so many points in our learning. Dr. Esha, I think just for the information, the flow of our discussion, we know that it will be a little bit different compared to our classroom teaching, because online some limitations are there. First, Dr. Esha will give us the history part, and from the history we'll take one by one points for the discussion and analysis and try to derive that what type of problem it is. We can prepare some hypothesis from the history. Next, she will provide us the information on the examination, and then we can try to derive that what are the clinical possibilities. At the end, some more specific investigations, which may be probably conclusive for the condition. Meanwhile, I think with analysis, we'll start the discussion first with the students. I hope that more students should be on the screen, not only Dr. Esha, because you know that with interactions, all of us can learn a lot. And meanwhile, our experts will always add something, suppose we are missing or something new to remember, or even something better for the presentation. And I think in this way, all of us will try to learn from each other. And at the end, probably we'll have the good information on the subject or the topic, whatever Dr. Esha has selected. I think with that, I request Dr. Esha to share her PPT and start the history part. Dr. Esha, please.
Yes, sir. Thank you, sir. Good evening, everyone. Should I start, sir?
Dr. Esha, your PPT is not seen on the screen.
Yes.
Yes, now it is seen. Can you make it full screen?
Yes, sir.
Yes, nice. Very nice. Go ahead, please.
Good evening, everyone. I'll be presenting a case on central nervous system. Presenting a case of 5-year-old male child Arham, first-born child to a non-consanguineous marriage, resident of Waracha, Surat, belonging to lower socioeconomic class from Ansari caste, presented to New Civil Hospital, Surat, with the following complaints. Weakness of lower limbs since past 3 days. The mother complains of the child not able to stand, walk or run and not able to get up from lying down position. At present, patient is not able to move both lower limbs and not able to sit. The child is not able to wear slippers on his own. The weakness is non-painful, progressive and was developed over a period of 3 days. The patient does not have complaint of altered or reduced sensation or pain over the face or any body part. No complaint of any urinary incontinence or retention. No involuntary movements were present. No history of fatigability or fluctuating weakness. No history of blurring of vision, double vision. No history of impaired sensation of smell. No history of drooling of saliva, deviation of angle of mouth, loss of taste sensation. No history of tinnitus or vertigo. No complaint of difficulty in swallowing or change in voice. Patient is able to talk in complete sentences. No present history of fever, myalgia, arthralgia, ear pain or discharge, skin lesions, irritability, seizures or altered sensorium. No history of abdominal pain, photosensitivity or skin rashes. No history of any recent trauma, wound or consumption of drugs or improperly preserved food items. Child is vaccinated for polio and has not received any recent vaccination. Past history. 2 weeks ago, patient complained of watery, non-blood-stained, non-foul smelling stools for which syrup, zinc and ORS was prescribed to him by a local private practitioner. The patient recovered within 4 days of treatment. No history of similar complaints in the past. No history of any other medical disorders or chronic medicine prescribed to the patient. Antenatal, natal and postnatal history. He was born to a 23-year-old mother at 39 weeks of period of gestation by normal vaginal delivery at NCHS. Antenatal period was supervised. Mother had taken 5 antenatal visits. Mother has received 2 TT injection and had taken iron, folic acid and calcium supplements. 1 antenatal USG done in 2nd trimester. No history of decreased or increased movements, fetal movements. He cried immediately after birth and weighed 2.8 kg. Immediate postnatal and neonatal periods were uneventful. Breastfeeding was initiated within an hour of birth and the baby was exclusively breastfed for 6 months. No history of NICU admission. Developmentally, the child has achieved all milestones appropriate for the age, but at present, the child is not able to sit. Immunization history, child is vaccinated up to the age as per national immunization schedule according to the history given by the mother. No optional vaccines were given and BCG scar is present. Diet history, the patient's total calorie requirement per day is 1350 kilocalorie per day, as opposed to with the patient is taking 1185 kilocalorie per day. So patient has 12% of calorie deficit per day. Protein requirement, patient is taking the required protein requirement per day. Family history, no history of similar complaints in the family, no history of early unexplained deaths in the family, and no history of other medical illnesses in the family. Patient belongs to class 3 Kupuswamy scale according to Kupuswamy, modified Kupuswamy scale. Summarizing according to the history, a 5-year-old male child, first by birth order, born of non-consanguineous marriage, full-term normal vaginal delivery, all developmental domains achieved appropriate for age and fully immunized according to National Immunization Program, presented with complaint of development of acute onset symmetrical, proximal and distal lower limb weaknesses, progressing to inability to move them at all within a span of 3 days.
Okay, can you stop sharing?
Yes, sir.
I think within a short time, Dr. Isha has provided lot many informations.
Yeah.
Dr. Apurva, I'm not sure. From
Yes, sir.
BJP, can you keep your video on so
Yes,
that
sir.
we can have the discussion?
Yes.
Dr. Isha also, I hope that your NEET is working properly.
Yes, sir. As of now, it's fine, sir.
You know, if the video is on, we feel that we are discussing in the presence of each other. It gives the feeling of live discussion.
Has it started, sir? Video?
No, your video is not probably seen on the screen. Dr. Isha and both of you.
So actually, I just had some network issues, so that is why
Okay.
I'm not
Okay,
keeping
okay.
my video on, sir. Yeah.
Okay, no problem, no problem.
Thank
I
you,
think
sir.
let us keep this first chief complaint. Dr. Isha, you are sitting in the OPD
Yes,
and
sir.
this patient enters your room and mother complains, as you said, that 5 years old child is brought with this weakness of both lower limbs of 3 days duration.
Yes, sir.
What other questions would you like to ask so that probably it gives some idea that what type of problem it is?
Sir, our first question would be whether the child has any recent history of trauma to the
Okay.
back, spine, or any history of fall down, followed by
Right.
which the patient developed weakness. Apart from that, if the patient says no to that, then we can move on to other questions. So, for example, sir, we should actually
And suppose the answer is in yes, then what will be your thought process? By chance, you know, some other patient may come to you with the complaint, what you narrated, and it is in the affirmative that yes, it is there.
Okay. So then if the patient has trauma over spine, then spinal cord trauma would lead to lower limb weakness in the patient.
Okay.
So we have an entity called as traumatic neuritis as well. And
I think before that, any specific question, you know, that this inability to walk or inability to get up may be due to the several reasons, broad categories. I think what you would like to define, is it with pain or without pain?
So the onset, sir.
Onset, yeah. How it's
See, he says that it is 3 days history. But what you need to ask, I mean, what we would expect is you need to ask how did the child develop a weakness? Whether suddenly when he woke up and he was not able to walk,
Or initially when he used to walk, he used to fall down. He had a difficulty in running, and then gradually he stopped sitting. So that pattern is also important.
Yeah.
Is also important. And when they complain that gradually, the next question would be, was it because of pain or it was not with the pain? So that's the thing usually we ask.
Dr. Isha, can you focus on this part? You know why I'm coming to this point? You know that when the mother complains or the child is complaining, not able to walk, first you would like to differentiate. Is it really due to some pain or it is neurological weakness?
So it was like a progression of a weakness,
and once you define it, probably you can have the different approach. Next question will come, as Dr. Harshit may say, that how the problem started. I'm sure that should be asked in details. That what exactly the child was doing. Was it sitting, or was it in the school, or was it even during night sleeping, and how they noticed the weakness. And even before the weakness, whether the child had any issues, sometimes they will complain directly the weakness only. But before that, if you ask even, then they will say, yes, there was some mild fever, or there may be some vomiting. He was not eating properly for 2 days or so. All these problems, they will not give the importance. But I think that may be the important points to you. So I think that's the point, that how you will try to derive. And once you decide, then probably you will go elaboration that what type of the issue, which part is involved, in what way it is involved, progressive or not progressive, and progression in what way, whether it is symmetrical, asymmetrical, and then even associated some other problems or complications, the difficulty in breathing or difficulty in swallowing, or there is some change in the voice or something like that. So I think this type of series of questions you may start it. Dr. Isha, now can you focus in your patient that how situation develop?
Sir, so if we start the complete history, the patient initially a week or 2 weeks back, patient had a complaint of loose stool. So after that, they have taken oral medications for the same, and then the patient was completely all right within 4 days of taking medications. Then the patient has come to us, and since 3 days, the mother complains that initially the child was not able to, at 5 years of age, the child was developmentally normal before this. So child was able to run around and play like normal, like other children of the same age. But within a span of 3 days, the child was initially not able to play and run around like other kids. And then gradually patient's weakness developed to an extent where right now when the patient has come to us, the patient is not able to get up or sit on his own.
Suppose if I give the example, and that's why, in the exams, never go biased with your case. Try to think broadly. Suppose in some other case, mother complains in this way, the child was having the fine fever, cough for a day or two, and later on, there was pain at the lower limbs, and actually not allowing us for proper even the movement. Now, due to the severe pain, he is not walking. What will be your thought process?
Yes, very good.
What will be your thought? In some other patient, suppose in your patient, this type of presentation is there, but some other child is brought to you with this type of the problem. Then what will be your thought process? And there is no history of trauma, no history of fall. So probably it is not traumatic. Then what is the problem? And even suppose to help you, if I give some clues that when you are examining, child is not allowing you to touch, even so painful or tenderness.
So such tenderness can be seen in viral myositis.
Yeah. So that's the point. Coming to the point, right? So
any other thing?
Yeah. Anything else? Yes.
Apart from myositis, sir, is a very good clue that the child is not allowing you to
touch even.
He complains of pain. There are two different things. One is He complains of pain, but he allows you to touch. And other one, what sir has told you is, he is not allowing you to touch. That means that area is tender.
Ma'am, it can be.
When does it happen?
Ma'am, it can happen in.
To move with the tender.
Ma'am, that is also present if the patient is developing cellulitis in that region.
Okay.
Then
Still one more pediatric patient.
DVT, ma'am.
DVT. Okay. Very less likely.
Yeah. Dr. Isha, what you said, cellulitis or something, suppose the deep vein thrombosis, there should be some background to develop the deep vein thrombosis.
Yes.
Suppose in a case of nephrotic syndrome, and such a child complains of pain or tenderness, I think I will first focus that this is likely the problem. Then I will look at the swelling and other things. But
yes.
you know, in our pediatric patient, of course, in adults probably without this background, it may develop. But in children, usually deep vein thrombosis is due to as a part of problem or complication of some other disease process or part of the treatment. So directly they will not come to you, right? And cellulitis, you know, before that the child has a very high grade fever. Here fever is absence or mild fever.
Yes.
Or mild fever. Fever may not be the big issue in such conditions.
Sir, scurvy.
Okay. I think you are, you know, in the exam, Isha, exactly it happens so. You are providing the different questions to the examiner. And
Prompting the examiner. He wants you to take to the simple things. Anyway, yes, good.
Good, but I think scurvy also may not come. Suppose somebody is asking me, since several years I have not seen a single case of scurvy. But yes, in the past when I was probably years back as a resident or junior person, I have seen. But that scurvy will be absolutely due to the pain, and that's why even we say pseudoparalysis. In the scurvy, so much weakness that the child is not moving at all due to the pain, and therefore we label it as a pseudoparalysis. So that can happen, but that would be the different situation or different presentation. Of course, one of the differential diagnosis, if you keep it, I think it's not totally wrong. That's right. Something else. You can go ahead now.
Sir, myositis and polymyositis can also present.
I think something inside. Yeah. Something inside the muscle. That's what the sir is prompting.
In inflammatory myopathies.
Myopathies usually are not painful, except few. I mean, they are different myopathies, but usually they are not painful myopathies. So they are painful neuropathies rather than painful myopathies.
Yeah.
Painful muscles are myositis, and the myositis might be different, like viral myositis, like dermatomyositis, and so on, like connective tissue disorders. But the sir is asking you something which is showing a tenderness with or very mild fever, no other history, and child is unable to move the limbs. Think of still a common thing. Still a common.
Yeah.
Many a times, and I think it's still being put as a long case, sir.
Yeah. We are going to discuss only 2 hours. 2 hours, only one case. And I'm sure that every simple point we can dissect and all of us can learn.
Okay.
Dr. Isha is giving so many, I will say it's, Dr. Isha, your thought process is good. I will appreciate you. That these are the things which will come to your mind. Then you will think yes or no. And I think that's the thing that how we go ahead. Anyway, anything comes to your mind?
Where the muscles are attached.
Via tendons to the bones.
The tendons are the end points of the muscles.
Yeah.
Attached to somewhere.
Tenosynovitis.
Okay.
But that does not lead to the, see, there is a very good differentiating point. If it involves the joint, then there will be a difficulty in the walking. But when it is a tenosynovitis, there will be a painful walking. That's a differentiating point.
Yes, ma'am.
Painful walking, but not inability to move the limb.
There will be the limp gait, but able to manage.
Yes, that is tenosynovitis.
Yeah,
I recently had one patient, 5 years old, who had a synovitis at knee joint. But he was moving, like he was not allowing us to touch, but he could walk. Sir is telling that he cannot walk. He or she, yeah. And it is a tender.
And it is tender.
So whenever it is a tender, it is an inflammation.
Yes.
Okay. So when there is an inflammation, it will not allow you to touch. If it is involving the skin, you get the redness. If it is not involving the skin, you will get the hardness. When you get a hardness, it is a muscle. And it is a muscle, it is a myositis. When it is a myositis, there are multiple causes. Something which is coming on the way to the muscle.
Fascia.
Fascia usually does not, because they are the separating elements.
Anyway, I think let us you continue to think at the even part of the discussion, you will get the answer.
No, sir, this is very good point you raised. And I think it is very good learning.
So suppose if now we come to the second group, and therefore always what we say that try to categorize the symptom. I think suppose the symptom is without this pain, then you can focus that this is something different, whole group of the disorders. Suppose as in your case, as you said, there was no pain, but how it started, I think Dr. Harshit said, not only in this case, but any symptom, any, I will say, system, always onset is very important, and therefore onset, duration, progress, what we are discussing, I think even today also it is absolutely right. How the disease started, what child was doing the previous moment before this illness, that is very important. And then what is the duration? As you said here, 3 days. So it's acute. That's right. Yes, now, what is the progress? I think that you can take it. That what was which particular limb was involved first, and then how it progressed, and whether the progress was rapid or slowly or whatever way. I think that you can take it, discuss later on. Take it, I would say, details. It will give some more ideas. I hope that you have asked all these points to mother.
Yes, sir. Sir, the mother has not given history of any particular limb involved, getting involved before the other or being involved more than the other. She is saying that it started in both the limbs, sir.
Okay, both the limbs, right?
There is no limb predilection to it.
Okay. And first, as you said, the lower limbs?
Yes, sir.
And then was there any progress?
Yes, sir. Initially, the patient was not able to play normally like he used to before. So then gradually, patient used to just, next day, mother specifically said that he didn't even go to play. He just sat. He was just sitting and doing whatever he wanted to. He didn't feel like getting up. And when asked why, he's like, he doesn't feel confident putting his legs on the floor. He was like, he might fall down. He had that weakness in the lower limbs. And post that, within the next 48 hours or so, the patient was not able to get up from the bed by himself.
Right.
Like sit from supine position. So
that
is how.
Now, I think if I ask you directly, if you try to define the anatomy, that lower limbs, yes, now not able to get up, that what does it indicate? Now further involvement of which part of the body?
Sir, this is, sir, the disease is progressing and now it has involved proximal limb girdle muscles. Sir.
I think before that, already you said not able to get up. That means it is likely the involvement of trunk.
Yes, sir, trunk.
So now from lower limbs, it has progressed the trunk. Then further, what happened?
Sir, then they have come to us. Now in the OPD, they have come to us.
Okay, that means upper limbs are not involved.
No, sir. The involvement is only up to the trunk.
Fine. Now, always, in any disorder, try to think in this way. Not only CNS, but any system. That anatomically, which part is involved. That will give you the idea that where is the site of lesion. Second, always try to think that what type of pathology it is. It is some traumatic, it is infective, it is non-infective, it is SOL, degenerative, something like that, what we are thinking. And from that, try to define, is it possible to give some etiology? When you are, I think, having this thought process in this direction, it will give you lot many ideas to decide that what type of the disease it is. Now from this your narration, what does it indicate? It is what type of the disorder it is. I think before that, decide what is anatomy. Where is the problem?
Sir, since the patient doesn't have any other complaints pertaining to the affecting the sensorium of the patient or having seizure or
Yes, very good.
sir, in the first glance, sir, it appears that the patient preliminary has motor system involvement because there is no tingling numbness associated, nor the patient has lost the sensations over the
Dr. Isha, if I ask you the direct question, always nervous system we are trying to derive. It is the involvement of central nervous system or peripheral nervous system.
Sir, this looks like involvement of peripheral nervous system.
Okay.
More likely, neuromuscular involvement is.
I think we'll go step by step, right? Suppose if you say peripheral, very next question it is going to be there in the exam. Why not central nervous system?
Sir, there is no.
Some points you have mentioned. You can take it further.
So there is no cognitive impairment, no alteration of sensorium, no seizures, history of seizure, speech and behavioral abnormalities are also not seen. And sir, the patient does not even have complaint of tightening or tightening of limbs, sir. So indirectly maybe pointing towards absence of spasticity.
Very good. Now suppose if you focus for the peripheral nervous system, you know the different sites. It can be from the anterior horn cells, it can be peripheral nerve, it can be neuromuscular junction, it can be even the muscle itself. Now from all these points, suppose if you say periphery, what is likely in our case, where it's which part is likely involved anatomically? Can you try to think in this point? Then Harshit will explain us everything in detail. But I think before that, you try. That I think Dr. Apurva what mentioned BJMC. I'm sure that BJMC Pune. Yeah. I'm not sure whether it's student or some.
Sir, I'm student.
So then I'm waiting for your response. I will say. Yes. You should help Asia, right? Yes. So can you take this point?
Sir, it is
Dr. Asia decided that it is the peripheral nervous system problem, not the central. I think fairly good she tried to answer. Now the periphery, as I said, you have any point to say that with the anterior horn cell, peripheral nerve, neuromuscular junction, or muscle? Can you try? What is your idea?
So I think it is like nerve root or along the course of the nerve.
Okay, why do you call it nerve root? Suppose nerve root problem is there, what will be the very, very important complaint, chief complaint?
The radicular pain.
Yeah, absolutely. And somehow Yasha has not mentioned at all. Or at least if something is there in your mind, you can ask. But pain is such a thing that nobody can hide. Without asking, on the contrary, child or mother will mention, because pain is always disturbing to us. Anyway, so pain is not here, but suppose if it is there, exactly you are right, that it indicates a root pain. Anyway, something else, you can go further. Suppose directly if I ask you, is it the anterior horn cell? Because when we were resident, we used to get many patients with the involvement of anterior cell disorder. So it was easy for us to think that this is your anterior cell disorder. How they present. And now if I try to help you, remember one prototype condition for each group. Anterior cell for us, it was very classical poliomyelitis.
Polio. Yes.
Right? So how the poliomyelitis patients will present, I think then most of the anterior cell disorder will present in this way.
So polio is not always symmetric, and
Okay.
and the involvement is also patchy involvement.
Okay. Anything else?
Here,
Very good.
here she has described ascending involvement, like from distal to proximal. That is not seen in polio.
Peripheral nervous system disorder, most of them having the common presentation weakness. But every group has some characteristics. You can try to catch. Suppose for anterior cell, any characteristic. So another I will say disease, if I give the idea so that you can think over it. I think you must have seen spinomuscular atrophy, right? Yes. SMA. You must have seen SMA. SMA is the another example for the anterior cell disorder. So what they are the characteristic, I will say, over the tongue, if you have seen?
The fasciculation, sir.
Yeah. So fasciculation is probably the characteristic of anterior cell. Besides all other points, you can take it consideration. I'm just giving the hints. Now try to think very specific characteristics of each group. Suppose if it is a peripheral nerve problem, how they present? Isha, you can take it now. I think one by one. Dr. Isha?
Yes, sir.
Suppose if it is a peripheral nerve problem, then how commonly they present? That means what starts first, then what is the next complaint, what are the other symptoms, how they progress, they have some characteristic. You can take these points.
So peripheral nerve disease is present with signs of LMN, lower motor neuron lesions.
Okay.
So that are specifically, sir, hypotonia. Then, sir, areflexia is there, sir. And, sir, usually, so sensory loss is not motor loss. Motor loss is more dominant feature than sensory loss, sir.
But sensory loss is there or not?
Sir, no, sir.
What do you say peripheral nerve? Then what are the components of peripheral nerve? Only motor or motor and sensory both? Dr. Isha? Suppose in a case of diabetes mellitus, which is not common for us, but the adults will learn that they have the peripheral nerve involvement. How commonly they present complaints?
Sir, their common complaints are slipping of footwear from their tingling numbness sensation, sir.
What the tingling numbness indicate?
Sensory.
It's a motor or sensory?
Sir, altered sensations.
Yeah, that means sensory system is involved. Yes. Motor, as you said, weakness is also there.
Yes.
So
Sir.
what I mean to say, peripheral nerve problem, commonly motor and sensory, both symptoms you will get it. Anything else? Any other characteristic of the peripheral nerve problem? From the anatomical distribution point of view, proximal or distal, any specificities there?
Sir, distal are more affected than the proximal.
Yeah, and that's why what we say then, gloves and stalk pattern.
Yes, sir, glove and stalk.
Right. That means usually it starts in this way. Of course, any disease with the progressive, probably the whole thing is involved. You cannot differentiate. But if you get the details how it started, that gives the idea. The peripheral nerve also, the ones they say that started with more extremities, feet and the hands, later on progressive, then probably it gives the idea that yes, it is the peripheral nerve problem, and with the sensory system.
Yes, sir.
I think in the negative history, you asked something, no diplopia or vision problem or something. What was your idea?
Sir,
I'm sure the negative history you mentioned something regarding the
yes,
visor
sir.
and eye movement. What was your idea?
Sir, regarding the eye movements, I wanted to rule out if the patient has any form of ophthalmoplegia.
Yeah.
Because if that is there, then that would signify involvement of cranial nerves 3, 4, and 6.
And in which condition it is common?
Sir, in Miller-Fisher syndrome, which is a variant.
No, I don't know the even GBS Miller-Fisher. I don't think just group. In which type of the anterior horshair, peripheral nerve, neuromuscular junction, in which group this is ophthalmoplegia is common?
The neuromuscular junction, sir.
Yeah, which one?
The
Myasthenia
myasthenia
gravis.
gravis.
Yeah, and myasthenia gravis, how they complain, how they disease start.
Sir,
Before ophthalmoplegia, what they complain?
Sir, ptosis.
Okay, before that, general complaint. What happens in the morning? What happens in the
The
evening?
diurnal variation, sir.
Yeah, so fatigability is the problem.
Yes, sir.
And you know that it is particularly more as the day advances.
Yes, sir.
Yes.
With the fatigability. So I think that of the story, with that later on with the progress of the disease, there may be the ophthalmoplegia, maybe the ptosis, maybe I will say so many other things, right? Facial weakness. So I think that will give the idea regarding neuromuscular junction.
Yes,
But
sir.
then what happens with the suppose muscle is only there? Some myopathy, yes, Harshit was giving some examples of myopathy. Suppose it's simple myopathy. Then how they complain?
Proximal muscle weakness more.
Yeah, that means, in myopathy, commonly, the weakness is proximally.
Sir, and the reflexes are preserved.
Reflexes we are not examining. We are discussing only history part.
Yes, sir.
Right. On examination, again, we'll come back. But I think from actually, what is the point which I want to bring to your notice? Simply just from the description, if you go in the details of this history, many points you can derive and you can decide, is it neurological problem or something else?
Yes,
Or
sir.
suppose if it is neurological, you can decide it is central nervous system or peripheral nerve. Peripheral nervous system. If it is peripheral nervous system, you can decide that which component is involved. It is the anterior horn cell, peripheral nerve, neuromuscular junction, or muscle. I think simply, but as you get the more information, even further examination will confirm your possibilities. And I think that works very well rather than jumping to some condition or diagnosis. I think let us take share the opinion or more details from Dr. Harshit. Madam, can you take in details that how simply
Yes.
from the history we can try to differentiate? Please.
Sure. Basically, I would always prefer that whatever the clue you want, don't get biased with the diagnosis first. What is important is try to elicit the history in detail. The history starts with the complaint, the chief complaint. So whenever the person describes the chief complaint, the next we will try to elaborate the chief complaint only. That is the first thing. Say, for example, in this patient, there is an inability to move the limbs and inability to sit. So our job is to identify how it developed, because some idea comes to the mind that there is an acute onset and it is not a chronic. The first thing is the history. When you want to put a primary diagnosis, the first thing comes is it an acute or it is a chronic? If it is a chronic, it must be a long-standing gradual progression, and patient would you would complain that the weakness is present for last 1 month, 2 months. Here the history is a short. So the first thing which comes to the mind, it is an acute onset because it is a short history, less than a week. If it is more than that, it will be subacute. More than 4 weeks, it will be chronic. This we keep in the mind first. Second, when it is an acute, how did it develop? Because the next question comes is, which area of the body is involved first? And then how did it progress? So when you ask the first question, when it is an acute, which area developed? But if you ask the history, then whether he was going to the school, he was not going to the school. Whether he had a history of fall, he came from the school. Whether he could walk, but he couldn't run or he couldn't climb the upstairs. That suggests that the complaint started with the lower limb and not with the upper limb. right? When it started with the lower limb, it started with the girdle weakness. That's why they cannot run, they cannot stairs. Second thing is, initially he could walk, but he used to take a support. Then the next question comes is, could he sit when he was sleeping down? So supine to sitting, that shows the paraspinal muscles. So if this is not involved, means it is only the involvement of the proximal muscles or distal muscles of the limb. Then gradually the history comes that first day he could walk, but he used to take a support. Second day he couldn't get up from the bed. That suggests that this could be a progression of weakness, because he was not able to walk and now he is not able to sit. So the weakness has progressed from lower to the upper part. When it has progressed to the upper, it has involved the lower torso and then the upper torso, right? The next question comes is it he able to swallow the food or not? Because that suggests the weakness has progressed still up or not. Then you will ask whether he is able to speak or not. The speech is clear, but the speech is low pitch, such as the laryngeal muscles are also getting involved. Then here comes the what the sir described is whether there was a difficulty in eyes. He was very much focusing on eyes. We are not concerned with the diagnosis, but the eye movement itself suggests that you should go for the complaint to the of the higher functions and the cranial nerves, right? So you will ask the involvement of a cranial nerve. Now you know the function of cranial nerves, so accordingly you will ask the complaint regarding that third, fourth, sixth, seventh, weakness, the speech and everything. So that will rule out if there is a higher function. Higher function involves whether there was not only the alteration of sensorium. You can ask whether child is too sleepy or he is awake and normal sleep. That also suggests the first phase of involvement of the higher function, because if the child is drowsy, they would say that if the child remains sleepy, most of the time we have to arouse. That will ring your bell that this is involving the higher function, means there is involvement of the upper motor neuron system. When you know the higher functions, you will always ask, child is conscious and he is having a normal sleep rhythm. That is one. Second thing you will ask is he able to communicate with you the way he was before? Then you will ask for the cognition. How do you know the cognition? You will ask him to give a simple task, calculation, simple mathematics, and that will help you to know. See, the child is active, he is alert, but he cannot calculate. Say 6-year-old child, if you ask him to speak 1 to 10, if you ask him to speak the ABC, and if he cannot, that means the first higher function is getting involved, though they cannot complain that there is an involvement of the higher function. He says that yes, he is able to speak. He talks normally, but if you ask, then you will come to know that calculation is lost. So that is involving the reticular function. So that these are the small points which will help you to differentiate which type of higher function is involved. And if either of them is involved, then your diagnosis shifts from lower to higher upper motor neuron system. So before we stamp that this is a lower motor neuron system, we need to verify all higher functions of children as well. And that starts with the name of a child, name of a parents, calculation, and everything, right? So once you know that the higher functions are not involved, the next question would be to identify the cranial nerves. And for cranial nerves, you have asked the complaint. And that complaint includes the hearing, the taste. Is he vomiting out? Is he able to swallow? He says that I do not want to eat. These are the small things which you get from the pediatric patients. And when you ask them the diplopia, he won't say that I have a diplopia. You see properly how many fingers. Can you see there is a double? And if you see that, yes, he says double, what your next question would be? Because when he says that there is a diplopia, the mind starts thinking of a cranial nerves. But what sir said, it might be a weakness. So it happens with myasthenia. But the very important point is, in myasthenia, they don't develop the squint, which you develop with the involvement of the cranial nerves. In myasthenia, you get a drooping of eyelids. So you get a ptosis, but you don't get a squint. When you get a squint, means there is the involvement of the cranial nerves. you know. So these are the small points which we need to keep in the mind. Once you know that this is the upper motor neuron, you have derived the motor function and higher functions are normal. The cranial nerves are involved, or if they are involved, they are partially involved. Rest of the cranial nerves are normal. Then comes your motor system to identify, is it an upper motor neuron or it's an lower motor neuron. When it is a lower motor neuron, when you know that it is a neuropathy, it's a myopathy, it is a myositis or neuritis, or it is a neuromuscular junction involvement, then when there is an itis, the simple thing I'm telling, I might be going a little faster, but what simple thing what we need to keep in mind is when it is a pain, it must be the neuritis, it must be the myositis, it must be the involvement of something else. But when it is not a pain, it rules out the itis part. So that comes into the pathy. Pathy is weakness. So that comes into the neuropathy, myopathy, and the other conditions which are associated with the neuromuscular junction. So when it is, so what is important is when he develops a weakness, you ask if there is a pain or not, it's painless. So when it is a painless, then you come to the conclusion that yes, this must be the muscle or it is a nerve. And when it is a graduation of the weakness within a very short time, then it must be the neuromuscular junction. But when there is no graduation of the weakness, but it is not within a day, no diurnal variation, but it is over the days, then it must be the neuropathy or myopathy. And when it is a neuropathy or a myopathy, when there is a myopathy, it is a generalized involvement of the muscle. So the large muscle fibers are involved. The smaller muscle fibers, they continue to fire, and that's why you get a fasciculation. When it is a neuropathy, the muscles are good, they maintain, but they cannot move. And that's the way you know that this is a proximal weakness. So it is a neuropathy, it's a myopathy, it is a distal, so it's a neuropathy. So that gives a general idea that this is an upper motor neuron, lower motor neuron, which area is involved. So I think that should be the way we should sequence our history. See, everything neurology is purely a history. So if you take a history, no matter, but you should take a history in detail, keeping all conditions in your mind. And for every condition, what sir said excellently, that you should keep one prototype. So if you think that there is a neuropathy, you ask him to get up, and if you see the weakness is proximal, he is not able to get up, it confirms that this must be the weakness somewhere here. So for before the examination, for every weakness, keep one condition, identify and classify them into the different categories, and that's the way the history goes. So the history should not be the prototype that you involve all higher functions, you involve all cranial nerves. It is a relevant type. Relevant is when you know there is a weakness. So the next question comes, is it involving the brain or it is a spinal cord? So the relevance is higher functions and the cranial nerve. But if you start speaking all cranial nerves, then you will get diverted. I think so.
Thank you. I think Dr. Harshwati has given all the details in a, I will say, very simplified manner, but very, very important. And you know that what she was insisting, main small points in the history.
Yes.
And I think it reminds me, those who have seen or read the Mankey, you open the Mankey and the first page, what he has written, so I will say world-renowned pediatric neurologist, that even in this era of the sophisticated gazettes, is it worth to go for this history and clinical examination? And later on, he has explained the importance of history and examination in his first chapter very nicely. And I think the same thing what Dr. Harshwati was bringing to our notice. This is very important. Even Dr. Brajesh Udani, who is a well-known pediatric neurologist of this country, all of you must be aware, he says that 80% diagnosis can be revealed only from the history. Probably later on, even after the history, you can ask, and I think nowadays, in exam also, MD and the DNP, this is the method. At the end of history, the examiner may ask you that what you are expecting on examination.
Yes.
I think even you can clear your mind that what you are expecting on examination. And probably examination will verify that whether your thought process is right or it is deviating from your thought process. And at the end of examination, with the history point, if you put the summation, probably it should be fairly good to divide that what are the various possibilities, 2, 3 possibilities, and you can put it with the common happening 1, 2, 3, and most of the times I think we are right. And that's why one place I have written even that when we were studying, people say that medicine is not the mathematics.
Yes.
But
Neurology
now,
is purely mathematics.
but
Purely.
yes, but we are learning that medicine and particularly the nervous system is a absolute mathematics. Provided you know that how to calculate that sum. But if you are knowing as Madam was showing, that what is the method of calculation of sum, I think she was narrating, and I'm sure that if you do it, and examiner in the examination, Isha and Apurva, if I remind you, he's not interested that what case you have and how you are coming to this case discussion. He wants that how you are having the ideas of particularly the pediatric knowledge. Suppose the case of neurology, how you have the thought process. So I think that's very important point, and that's why we have taken more time for only these, I will say, complaints, and I'm sure that it is worth to give this time for this type of analysis. I'm sure that now from the history, these points are clear. Dr. Esha, you have mentioned some negative histories. I think without just sharing your PPT, can you take one by one points of the negative history?
Yes, sir. Sir, first of all, I have asked whether the patient has any complaint of altered or reduced sensations or pain in any part of the body.
I think I will try to discuss in this way. Esha will mention the point. Dr. Apurva will try to answer that what is justification for this point.
Okay,
I think
sir.
let us do. And something is there, Madam will add that this is the importance of this point. Dr. Esha, what was your point, first point?
Sir, I have asked regarding whether the patient has any altered or reduced sensations or pain associated with the weakness.
What was her idea, Dr. Apurva?
To look for sensory involvement. Is it a purely motor thing, or is sensory system also involved?
But Dr. Esha, how did you ask the child whether this is involved or not? You know, the patients don't know that how these sensations to be examined. So what questions, what I mean to say, what questions you ask them to derive this information?
Sir, regarding altered sensations, we can ask regarding that junjunati, or in the local language, we can ask regarding the tingling. Numbness might not that be appreciated by a child, but then tingling sensation is a very uncomfortable one. So that the child might appreciate and complain to it to his mother. That something is happening, maybe.
Okay. What are the next point?
Sir, pain. Is there any pain associated with the weakness?
Dr. Apurva, what was her idea?
Yes, sir. So like we discussed in the beginning, like if weakness is associated with pain, then the other diagnosis we have to consider.
As Madam gives a very good idea, which even I will remember. Itis or pathy. Right. So pain is commonly associated with itis,
inflammation. Yes.
Yeah. So anywhere inflammation probably you can consider. Even with the muscle, even with the nerve, right? And most commonly they have the, maybe depending upon the severity, but some element of pain you may get it. That's good idea. Okay. Next, Dr. Esha.
Next I've asked regarding whether the weakness is fluctuating, whether the child feels more weakness in the morning or evening, or whether he is able to get up in the morning but not able to do the same in the evening. So regarding that.
Dr. Apurva, I think you will have to answer. This will work very well.
Yes, sir. Sir, like for myasthenia gravis, like we said that as the day progresses, the weakness increases. So for diurnal variation of...
Very good. But suppose if it is this type of the presentation is not due to myasthenia gravis, is it possible due to some other reason? Maybe in some other case. These are the presentation.
Sir, hypokalemic periodic paralysis or any cause of any of the periodic paralysis comes in episodes.
Okay, but here you
know. We don't have the diurnal variation. Periodic and diurnal variations are different. Periodic paralysis is one where there is a weakness which lasts for few hours to a day and then they recover, which might be associated with some other complaint. But when it is a diurnal variation, sir said very clearly, it's a very good condition. I'll tell you later on. But the diurnal variation is one where there is a weakness which increases or decreases either in the morning or at the evening. That is called diurnal variation.
I think again, Madam is really, we are getting the good help from her. What she pointing out, and you know, in the medicine, please remember, each word, selection of word is very important.
Yes,
Because
say.
Because that selection conveys the exact meaning to the person. I have not to explain him. Once you say periodic, you know that it is in the form of some episodic. It remains for few days, goes for total recovery, and then again similar thing is repeated. That is the periodic. Here, what Madam said is different. That here it's a particularly with the changes of the hours of the day. That is the diurnal. And you know exactly what we use the word. So suppose again coming back to the question that it looks like diurnal, but on going the details, I felt that it is not myasthenia gravis, but some other condition mimicking to it. Then what it could be?
The Lambert-Eaton syndrome.
Do you see it in pediatric age group?
Sorry, I don't remember.
Myasthenia gravis. Do you see in pediatric age group? I mean, to younger child.
Isha, just for my clarification, I'm general pediatrician.
Sir is giving excellent clue. I tell you, sir, let me interrupt. Sorry.
Yeah,
Sorry.
Yes.
Giving an excellent clue that it is not a myasthenia gravis. Now you know that when it is a myasthenia gravis, it is a neuromuscular junction disorder. That everyone knows. It is a neurotransmitter defect, right? So now the things are very clear. When he says it's a diurnal, it's again the same condition where there is a neuromuscular junction involvement and neurotransmitter involvement.
Yeah.
Sir,
it happens only if there is a neuromuscular junctions. That's why. You don't. And it's Lambert-Eaton is again my type of myasthenia now.
Yes, Dr. Isha.
So botulinism is another disease that affects the neuromuscular junction.
But they don't have the diurnal variation.
Yeah.
Specific for the diurnal variation, fluctuation, more in the morning, less in the morning, more in the evening. Muscle, why? Simple thing. Just think simple. Simple is it's a neuromuscular junction. In neuromuscular junction, what you get is a neurotransmitters. There is a release of vesicles. Either they get exhausted because there is a production, or they are there, but they are not being taken up because the receptors are insensitive. That's the way the myasthenia gravis goes. So there is some other condition which this is acetylcholine receptors. These are some other neurotransmitters which also behaves in the same way. So what are the other neurotransmitter? Other question. I mean, we take it.
I think Madam has taken even the simpler way to explain you.
No, sir, this is easy way for them.
Yeah.
No, you don't have to mug up why myasthenia. It's a simple thing.
If you remember the basics, that neuromuscular junction is basically the neurotransmitter disorder. Is it either the excitatory or the inhibitory? What happens that when the excitatory goes down, then also the problem can develop, or inhibitory is up, then also the problem can develop with other various disorders. And very classical, Madam tried to give the help of myasthenia gravis, that BC the antibodies and then it is blocked, and therefore in spite of the presence of the neurotransmitter, action is not available. So I think similarly now in that direction, if you think whether anything, any condition comes to your mind.
Snake bite, because the receptors are blocked.
They don't have the diurnal variation. The receptors are blocked forever. It's a venom which is blocked. It's something like botulinum toxin. The same way happens with the snake venom because it's a blockage. Sir is very specific. Diurnal variation means there is a condition which is persistent. It has a diurnal variation. It becomes normal at some time and it deteriorates at some time.
Waxing and waning is seen.
Exactly.
What, sir? Sir, can you repeat?
Waxing and waning. That means it may even show some improvement then deteriorates, and even you may get some improvement. That type of the changes are seen. Ultimately, Yesha, then you will have to ask Arshati Ben if you don't know.
Sir,
Other neurotransmitters. That's what
Yeah.
I'm asking. Neurotransmitter, not neuromuscular junction receptors.
Ma'am, I don't know regarding.
little more. It's a treatable condition. It behaves like a cerebral palsy. Then the child becomes normal if you diagnose that condition. That's why sir wants to point it out. Think of a dopamine.
Dopa.
You remember the dopamine? The Dopa responsive dystonia. Previously, it was known as disease, but now it is a Segawa's disease.
Segawa's disease,
which is known as a Dopa responsive dystonia, because the dopamine receptors are at fault, which is now determined that it could be a genetic defect. The people behave like a cerebral palsy because they have a dystonia which is less in the morning. As the days passes off, the Dopa reduces, and that's why in the evening they find that they are fatigued and they become more and more dystonic like this. This is a typical posture they achieve. Especially it happens in the young children and in the school-going children. We find when they go to the school, they climb the staircase, they cannot climb the floor, and the patient continues to, the posture is this. So the patient continues to go for the physiotherapy, they don't improve. And moment you give a small dose of Dopa, Syndopa or Carbidopa, child becomes normal.
I think very classically Dr. Harshati described, and the same thing was in my mind. Long back we had this case discussion. So I think some neurologists brought for the discussion, but I thought, Dr. Isha, when this type of discussion will take place in the exam, when probably common questions to answer, then I think these type of questions may be put forward to you. And regarding some syndrome, to all the students, please don't jump for these syndromes. As a whole, the syndromes are rare. And if at all, probably you will go after these common conditions diagnosed. And what actually comment I was making, that I am general pediatrician, I may not be able to remember all the syndromes, even I don't try. If at all, probably I will later on verify this literature. And in the exams also, by naming the syndrome, don't invite the trouble, because then it becomes many times difficult. For the, I will say exam point of view I'm talking, it's very good that if you remember some syndromes and common conditions also. Very good. I think in the history part, we have taken the discussion. Yes, Yesha, you can take these negative points further, please. I think this is more important in the exam. That's why I'm taking in details.
Next, I've asked regarding whether the patient has any urinary incontinence or retention.
Okay.
So,
Apurva, what is the importance?
So to see if the bladder has been affected or not, like in transverse myelitis, the bladder is generally always affected, whereas in other cases like polio or GBS, it could be transient involvement of bladder bowel. It is not always affected.
Okay. Anyway, I think at this involvement of bladder bowel, then you can give the importance. Later on, probably we may take this point, that in which condition it is common and not common. I think Dr. Apurva has taken fairly good. Yes, Esha, next point.
Sir, I've asked next regarding whether the patient has difficulty in swallowing, change in voice, or difficulty in
I think
talking.
Madam was touching this point which you have taken up. Very good.
Yes.
Next.
So next, I've asked regarding the blurring of vision or double vision.
Okay, I think that also she took in the details for even understanding. Absolutely right. That's, and you have also incorporated. Good. Next.
Sir, next regarding any presence of involuntary movements.
Okay. What was your idea?
Sir,
Apurva?
Sure.
No, I think Apurva will try to answer. Then you can put your idea.
So like involuntary movements, it could signify involvement at the level of like basal ganglia and all that. So that's the answer.
In what way it is related, I will say connected to your case. Isha, what was your idea?
Sir, if I want, sir, I have not examined the patient. So we don't know whether the weakness the patient presents with is lower motor neuron or upper motor neuron. So just to sir know whether there is involvement of the upper motor neuron, I wanted to ask regarding any other involuntary movements. Very broad, get a very broad idea regarding if any other UMN signs are present or not before the
Okay.
exam.
Next.
So next I've asked regarding sensation of smell. Then I've moved on to sir all the cranial nerves one by one. So
Okay.
there I started with asking regarding any impaired sensation of smell. Then complain of whether drooling of saliva, angle, a deviation of angle of mouth, or loss of taste sensation.
Right.
Then whether the patient has any complaint of vertigo or balance, difficulty in walking. But then the patient, mother said that no, like he's not
Okay.
able to walk at all. Whether the patient has any history of fever, myalgia, arthralgia, any skin lesions that have appeared.
What was your idea? Apurva, why Dr. Esha is asking for the fever and some skin problems?
Sir, fever, like if there was preceding fever, like there is some viral etiology previously.
No, I think rather than preceding, she is complaining the fever at present. Am I right, Dr. Esha?
Yes, sir, at present.
Yeah. At present, she is asking.
So, like the infective origin of the illness.
Okay.
So dermatomyositis or any other itis problems that madam had.
Why don't you think of a joint, sir? He told, he asked you to remember or to recollect. The idea was to see for the joints. The muscles are attached to the joints, and if joints, you should think of a common condition like rheumatic fever. Dermatomyositis, which I might have seen only 2 patients by this time, 22 years. But see rheumatic fevers at least once or twice in a 6 month. So the rheumatic fever is more common, and we think that when there is a joint pain, involvement, inability to move the limb, and there is a mild or no fever, we think of a rheumatic fever first.
Please remember, I think what Madam mentioned, fortunately now rheumatic is going down, but yes, I think we should know, being the pediatrician, on the contrary, when it has gone down, it is easily missed, by chance it comes. So that is another thing which we should keep in mind. And very important point in the rheumatic fever, the pain or regarding the movement of these limbs, that's so painful. Even I will say, just if you are pulling the cloth, pulling the bed sheet of the patient, it also causes a severe pain, very severe pain. And I think that is the characteristic. And such a pain, if I have given this 1 tablet of aspirin and patient finds better, I think I may not go even for other confirmatory diagnostic test. This is these clinical tests have been given so much importance that rheumatologists insist that even it may not require the further confirmation except involvement of heart and other things. But I think for rheumatic arthritis, it does not require the confirmation. And I think that was the condition in my mind, which we are not able to recollect, Dr. Isha, but very important point. We should.
And which is the other condition which gets better with the brufen.
Yeah.
Was the femur or the bone, the long bones, which is when they complain of a pain, cannot move the limb for some time. If you give a brufen, the child will be fine. Which one has to keep in the mind, otherwise it remains. I mean, you always keep it. Osteochoma, always think of, and that's like a it's a tumor within the femur that they present with a weakness, inability to move the limb. It is episodic, and the condition gets very good once you give a single dose of brufen. But so that is a diagnosis. You have to ask the radiologist that look for this so that you don't miss it, because it gives a very good prognosis if you remove that tumor. So that goes like an aspirin.
Yeah, I think what Madam has raised the question. I want to remind these students. There are 6 examiners in long case, and different questions will come to the mind of the different examiners. And I think as you are getting the question over here, that dramatic response or some response, or I will say effect of the medicine, will help you to catch the diagnosis.
Diagnosis, yes.
Similarly, Dr. Esha or even Dr. Apurva, can you name some other condition where some drug even
Hmm.
will be the diagnostic for the condition? Can you give one more example?
Hmm.
Here now if I give the hint or idea, some important clue, that this tablet or this drug is not required or used in the condition of the treatment. But if I want to precipitate that condition for my confirmation, even you can give this step, this medicine, and that medicine is known to precipitate the condition. And condition is very uncommon, not so common, which can present either with a hematological presentation or neurological presentation.
Certain medicines to be avoided to have.
Yeah.
G6PD deficiency, G6PD deficient individuals.
It does not involve the brain.
Okay. Yeah, here, just try to listen to my, even this clue, what I'm giving the clue. That condition is not common. Sickle cell comparatively common. I'm putting this condition as even the rare. And it is even related to some toxin or some poisoning. And that may present with a hematological condition, the probably severe anemia or anemia. And or may go for chronically with some neurological involvement, what we say encephalopathy. And this condition, if I want to diagnose, that if I give the single tablet of, suppose if I give even the drug's name, I think then you can name the condition, phenobarbital. Suppose if I give the phenobarbital, it will be precipitated. And that is the porphyria.
Porphyria.
Porphyria like that. And it is it can cause the encephalopathy of longer duration. Just to give you some of the, I think if you want to score in the exam, even go with some these type of the ideas in your mind so that you can respond properly, right? So I think these were some drugs we were going. Similarly, is there any drug which can cause even the neuromuscular presentation, which is commonly used even? That toxicity is not commonly seen, but if they're given longer duration, yes, it can cause.
So
it causes the neuromuscular problem. It is called a neuromuscular blockade even. And it is antibiotic. Aminoglycosides. Aminoglycosides are known to cause the neuromuscular blockade if they are given for long duration. Anyway, Esha, is there any negative point?
Sir, the child has, I have asked whether there is any recent trauma, wound, consumption of improperly preserved food items or any drug ingestion.
Yes.
Then I've asked regarding any history of abdominal pain, photosensitivity or skin rashes.
For what purpose?
Sir, porphyria.
Yeah, then I think you should be able to answer.
Yes, sir.
Actually, I got the idea of porphyria from this your point which I noted when you are discussing. And that's why I came to my mind to ask this question to you. Then I thought that you will be able to answer immediately. Okay, anyway, but good point. Anyway, I think at the end of these negative points, I want to convey to all the students that negative points in the history should be mentioned related to your case. Not generalize. What are the points to be selected? That suppose whatever the condition you are thinking, and with that condition what is expected, whether it is present or absent, that you should mention. That will either strengthen your possibility or exclude your possibility. Second negative point, group of the negative points should be taken, which are related to the differentials. That means differential diagnosis, so nearby differential diagnosis. And third, what are the expected complications of the condition, whether the condition is with the complication or not. So I think keeping in mind these 3 points in your mind, we should find out the negative points. But I think you have, Isha, done the very good job in the history. Very nice. I think now at the end of this discussion, always in the exam, MD or even the DNP, it is routine now that what is your inference or what is your possibility? What is your summary in the short what the people are asking? In the summary, we don't repeat all the history points. The summary should be in the short of 5-10 sentences, which probably indicates that what is the site of lesion probably, what type of the pathology is possible, and if at all, if you can make the comment on etiology. So I think with that idea, you can give the summary. I think because Dr. Esha has presented, I asked Dr. Apurva that how will you try to put this summary in short in this patient from the history?
So like the child, yes, the child presented with weakness, bilaterally symmetrical weakness, which progressed over 3 to 4 days, and the child is developmentally normal, completely immunized, and
I think your attempts are good. Please continue. Go ahead. You can add some more points.
History of gastrointestinal complaint.
Okay.
3 to 4 days back. That is also important.
Right.
And
okay, Isha, can you make the attempt?
Yes, sir. Sir, so to summarize it, we have a patient, 5-year-old male child, who is fully vaccinated and according to National Immunization Program, and has presented with a complaint of acute onset of symmetrical weakness affecting both proximal and distal, both lower limbs, bilateral lower limbs, which is progressing to inability to move them at all within a span of 3 days, with a past history of preceding acute gastrointestinal gastroenteritis 2 weeks before the onset of weakness.
Okay. What you are deciding? What is your inference from this presentation? What are the problem it is? Try to answer in this way. Is it CNS problem or something else? If CNS problem, what is the likely anatomy? And from that anatomy, what is the likely pathology? What type of disorder it is?
Sir, from the history, it appears that we are dealing with the CNS pathology, which is primarily affected the motor component of the CNS, and maybe more likely towards muscle or nerve involvement, PNS, peripheral nervous system involvement, sir. And the disease we are dealing with is acute in onset, and
okay, good. I think
sir,
just
maybe
yes, sir. Isha, continue, please.
sir, maybe a post-infectious sequelae. We don't know the relevance of it, but maybe a post-infectious sequelae to what? To acute gastroenteritis.
Right.
Yes, sir.
Then what is your possibility? I think common you can put it. Nothing is wrong.
Sir, sir, to put it under a broad heading, we can say that it's acute flaccid paralysis, sir.
Yes.
And to enumerate the causes, sir, GBS, Guillain-Barré syndrome, can be transverse myelitis, periodic paralysis, traumatic neuritis, poliomyelitis, and
okay. I think Isha already, that's why I always try to define and use the multiple adjectives. I think here you said no fever, right?
yes, sir.
So probably no, then probably no inflammation,
Yes,
and
sir.
then probably acute transverse myelitis or conditions you may not consider,
Yes.
right?
Yes,
Polio,
sir.
I think already picture is quite different. Suppose if you want to put the polio, one of the possibilities, which type of the polio you will consider? Suppose by chance, even I may say that yes, I should put the poliomyelitis in my differential diagnosis. I will keep at the bottom, but I will keep it. Suppose some student comes in this way, then what type of the polio?
Sir, paralytic polio.
Okay, but you know, it is paralytic, but at present, with the present status of the polio condition in our country,
Yes.
if at all it is polio, what type of the variety of the poliomyelitis? If I give some even idea, is it wild due to the virus itself?
Sir,
Or is it possible,
vaccine.
or is it possible due to some vaccine, OPV?
Sir, vaccine derived
And
polio.
if it is due to the OPV, even which stage of this OPV? Is it due to the, I will say, same circulating virus, which has even probably now gone for the mutation? Or is it due to the vaccine itself? I think
Sir,
these questions may come once you have the good score or you have the very good ideas. But I think that also you can consider. Anyway, simply what I was trying to uh, uh, convey to the students that how you can convey this summary, and for that even spare some time, even put some points on paper so that you can refer it, and you can, when you are describing, probably you can have the good performance. Here you can put in this way, try to, neurologically find out the proper adjectives. That adjective will help a lot. Suppose here if we try to decide, what even the madam was also giving the hint, that regarding this condition is the acute, subacute or chronic. I think here we can say it's a acute, right? You will agree with me with the 3 days duration.
Yes.
yes, sir.
Second, you decided that from the anatomy point of view, it's a peripheral nervous system problem.
Yes, sir.
Already from the discussion, we tried to derive that it is the probably peripheral nerve involvement. Am I right?
Yes.
From that you can decide that it is not the at present infection, but probably post-infective, because the history of diarrhea 2 weeks back and now, so it's a probably post-infective. Second, you can say that it is the starting from the lower limbs and progressing. So it is the ascending, right? It is the ascending. And second, even you can say it's a progressive, right? So now you can, if you put all the points together, that from the discussion, it becomes obvious that it's a neurological condition, probably with the involvement of peripheral nervous system. It is acute or onset, which is probably post-infective, and in the form of these polyneuritis, it started from the lower limbs and progressive, that is acute ascending post-infective polyneuritis. And with that conditions, if you consider, very few possibilities are there. I think that's why you can put forward, and you can say that it is without any problem or complications, because at present there is no any respiratory problem, neurological problem, any encephalitis, right? Any syndromic presentation. In the absence of all this manifestation, you can say it's a non, or I will say typical presentation of this GPS you can consider. Anyway, I think I will have to keep in mind regarding timing also. So now, Dr. Harshitaben, she should go for this examination.
Yes, sure, because I was just going to.
Yeah.
Let's have how to have an examination.
Yeah, Dr. Isha, now you can go for your PPT and examination.
Yes, sir. General examination. Patient is conscious, cooperative, well-oriented to time, place, and person. He looks well-nourished. The patient is in supine position. Vitals. The patient is vitally stable. Anthropometry. Patient has height of 104 centimeter, weight of 15 kg. So weight for height Z-score is less than -1 SD, MUSE of 13 centimeter and head circumference of 50 centimeter. Head-to-toe examination. There are no signs of pallor,
I
icterus.
think, sorry, Dr. Isha, to interrupt you. In the anthropometry, always put your interpretation, not just figures. Regarding now your interpretation, nutritionally child is normal or abnormal?
So nutritionally, the child is normal, sir.
Yeah, so simply mention that from these parameters, it is obvious that nutritionally child is good, right? That means no any degree of malnutrition. Okay.
Yes.
And in the exam also, not only the figures, but you will have to put your interpretation.
Yes, sir.
Okay.
Head-to-toe examination. No signs of pallor, icterus, cyanosis, clubbing, lymphadenopathy, edema seen. There are no neurocutaneous markers or skin rashes seen. In eyes, there is no icterus and no ptosis seen. There are no dysmorphic faces. Expressions of the child are normal. No neck stiffness or neck swelling is seen. Back and smile appear to be normal and genitals are normal. Central nervous system examination, higher mental function. The child is conscious, alert and cooperative. Appearance and behavior is normal. Oriented to time, place and person. Language is normal. Normal speech, fluency, comprehension and repetition. Cranial nerve examination. Cranial nerve 1, normal sense of smell. Second cranial nerve, grossly vision is normal. Pupils are round, regular and reactive. Color vision is normal. Cranial nerve 3, 4 and 6, pupillary reflexes are present. Extraocular muscles, full range of movement is seen. Cranial nerve 5, sensory intact. Motor, opening of the mouth without any deviation is seen and jaw jerk is absent. Cranial nerve 7, no facial asymmetry or deviation of angle of mouth seen. Cranial nerve 8, grossly hearing is normal. Cranial nerve 9 and 10, palatal movements present and equal. Gag reflex present and uvula is in midline. Cranial nerve 11, no drooping of shoulders seen. Cranial nerve 12, tongue movements are normal and no deviation of tongue to either side is seen. Coming to motor system examination, the bulk of the muscles. The bulk of the muscles is adequate and bilaterally symmetrical in both upper and lower limbs. Tone, hypotonia in both the lower limbs. There is normal tone in both the upper limbs. Assessing the power is grade 5 at all the joints in all movements of the upper limb, mainly the shoulder joint, the elbow joint, the wrist joint of both the right and the left side. Coming to movement of the hip joint, on both the right and left side, the power is 0, grade 0. Same at the knee joint, ankle joint and toe movement. Both left and right side, the power is grade 0. Reflexes, superficial reflexes, corneal, conjunctival, abdominal and Grammastic reflexes are present. Plantar reflexes are absent on both right and left side. Deep tendon reflexes, the DTR of the upper limb, biceps, triceps and supinator reflex are present in both right and left side, but the knee jerk and the ankle reflex is absent in both right and left side. Coordination of upper and lower limbs could not be elicited. Involuntary movements are absent. Sensory examination is normal. Cortical sensations are intact. No signs of cerebral dysfunction present. No signs of meningeal irritation. Gait cannot be examined. Skull is normal in size and shape. Anterior fontanelle is closed. Spinal, in spine there is no deformity, swelling or tuft of hair seen. Coming to other system examination, cardiovascular system is normal. S1, S2 is heard with no added murmurs. Respiratory system examination, chest movements are equal bilaterally. Normal vesicular breathing sounds in all areas and no added sounds present. And per abdomen examination, the per abdomen is soft, non-tender, and there is no palpable organomegaly.
Okay, can you stop sharing? So, Dr. Apurva, I think, can you take it, anything abnormal in the general examination?
Sir, general examination, sir, it is fine. And CNS examination, I'm fine.
Okay, suppose in similar patient, I found the hypertension. How will I will explain?
Sir,
It was really great surprise to me that rest of the general examination points were fine, but the blood pressure is quite high.
sir, it could be just due to like because the child is scared or something. So, or otherwise it could signify.
No, child is on the contrary quite cooperative, allowing me for proper examination, measuring the blood pressure. 5 years old.
So, then it could be a sign of raised ICT. So we have to look for other.
You know, then other signs of raised ICT should be there.
Yes, sir, like vomiting, headache,
Yeah.
and irregular respiration, but all that is not there.
So in the absence of all other signs of raised pressure, probably I may not consider isolated hypertension. But I think this hypertension, suppose if I give the clue, it's a part of your thought process. Same disease, probably with what you are thinking. But the hypertension there, what does it indicate? And with that, even I got one more point also, that there is some tachycardia also there.
Autonomic disturbances.
Yeah.
Yes, autonomic disturbance.
So autonomic disturbances are known in which disorder among these which we are discussing, Dr. Isha?
GBS.
GBS.
My point was that please keep in mind the blood pressure. As a resident, probably we forget it. But suppose in some patient, if you are and I think GBS is not uncommon in the practice, so never miss to measure the blood pressure. Look at the proper examination of the pulse. See even some other autonomous disturbances also. And you know that type of presentation is just what makes it different. The prognosis, I think we'll take the help of madam. That suppose some patient with this sort of disturbances, without disturbances, does it make any difference in prognosis or something like that? Okay. Isha, jaw jerk never mentioned the absent. Mention in this way, elicitable or not elicitable. You know, that's a method. Reason is, you know, usually it is not elicitable. But suppose if it is elicitable, what should be my interpretation? Suppose it is easily elicitable.
It's a sign of UMN.
Pseudo-valvular.
UMN involvement, sir.
Okay, in short, it is considered as exaggerated. If it is elicitable, it is abnormal, right? That's just exam point of view somebody is asking. You should mention expression is normal. So what expression you are expecting in this child?
Sir, if the child has pain, so if maybe this child is able to talk, but if the child is of younger age, so that the patient might not be able to talk, but then the expression of the child would say that the patient is in some sort of discomfort or having pain.
Okay, Apurva, I think Esha is giving me the idea. You know, sometimes examiner is getting the idea from the candidate.
Sir.
Can you enumerate some CNS conditions, nervous system problems from the facial expression problem, which may be the characteristic, which will give you the idea? Can you give some examples that what type of the different facial expressions will probably give the clue for diagnosing the condition or considering the condition? CNS problem. I'm not talking as about the face because it is a very big chapter, but restricted to neurological conditions. That these are the facial expression will give you probably this idea.
So like in facial palsy, if the child is having facial palsy, then that could be a deviation of the angle of mouth to one side. The nasolabial fold will not be easily appreciated.
Apurva, you are giving one more clue to me. That there was this deviation of angle of mouth. I was thinking for facial, but I didn't get any other feature for the facial. Then what it could be? It was very young child. I will say just 6 months, 7 months old child. And apparently there was deviation of angle of mouth. I thought it is facial, commonly what we consider. But when I tried to examine in details, there was no any other feature. And then what is the likely condition and what is the another important characteristic feature from which you can say that this is the diagnosis, but it's not facial.
So but yes, absence of that muscle, the depressor.
Yes, very good. Which muscles? Apurva, which muscles?
Sir, depressor angular.
Stories around the face.
Very good, very good. But then how I will confirm that it is not facial and only this absence of congenital, absence of depressor angularis. What is the very prominent, I will say, other feature? from which you can say, yes, this is the differentiating point.
Dimpling.
Please remember, this nasolabial fold will not be affected. If you just look at the child, the selectively only angle of mouth, while in facial, you know, very commonly nasolabial fold is going to be there. Anyway, what are the other, I think, features which expressions we were talking?
The expressionless face of a child that can sir, point towards either myotonic faces, sir, or so hypothyroid child will also have a expressionless face.
Yeah, I think I'm looking, but classically expressionless. What we say, there is no expression at all.
Mask-like face is seen in
Mask-like face, yes.
That is in Parkinson, but not common in pediatrics.
Yeah, not common in
The same
pediatrics.
condition happens in pediatric age group.
Yeah,
The name of
yeah,
it. And it's treatable, only treatable condition.
yeah. I would say
Neurodegenerative condition is this, where you get a mask-like face, involves the basal ganglia.
any idea? You know that these expressions may be related to basal ganglia disorders, right? So it's a disorder related to that, and as madam said, neurodegenerative, mask-like,
Only treatable neurodegenerative.
yeah, treatable. And you know, I'm in the exam again. Please remember, the examiners like me will ask you the question with some idea. It will be useful, not just that what you are not knowing. We want to know that this is going to be useful in the practice. So with that idea, so madam has given the hint. Dr. Apurva, any point in your mind?
No, sir.
No? Okay.
Yes,
Isha?
yes, someone spoke, right? Who spoke it? It was right.
I think some murmuring was there, what madam has
Yes,
noted.
there was a murmuring.
Mobius syndrome. Mobius syndrome.
W. It starts with a W. Wilson.
Wilson
Yes.
itself. Not uncommon here. Wilson is known.
Mm.
Wilson is known. Yes, and then any other the expression problem? Even any infective disorder. Not so common, but yes, particularly it's a smile is important. The name is given to the smile, and the smile is not good. It is given the name, I will say, it's a cunning smile. Fortunately, now it is the infective condition, but it has come down, hardly seen. Tetanus, you can get this rhizus sardonicus, cunning smile.
Okay.
And please remember, in the case of rabies, always is the anxiety is seen on the face of the child. Very obviously you can say that afraid of air or water and very anxious child, and even conscious till death. That is very classical of the rabies, which probably you can remember. Anyway, I think these are just examples which may come to your mind, which you should. Yes, Dr. Arshwati Madam is probably giving some more hints.
Inverted V-shaped mouth.
Yeah, inverted V shape, the way in which she was doing. She was trying to show.
Yeah.
Myotonic faces would have.
Myopathy. Myopathy.
Yeah, yeah.
Myopathy are the inverted V-shaped mouth. It's like this because there is a hollowing here and there is a drooping here. So you get an inverted V.
And therefore, even the name is given to that face is myopathic face.
Yes.
Because in myopathic face, this is very classically, these muscles are wasted and therefore mouth is also getting changed in the V shape. Okay, I think coming to the point of Isha, now you can give the positive findings of CNS examination. We'll have to keep in mind timing also. So I think you can start from the higher function to this bottom and mention only positive findings, which you have examined in details.
Sir, in CNS examination, sir, so higher functions were normal, sir. On assessment, higher functions were normal. The cranial nerve examination, sir, was also normal on both the sides. Motor system examination had positive findings. Regarding the tone of the muscles, the tone in both the lower limbs was decreased and the tone in both the upper limbs was normal. And in power, sir, the power of all the joints in upper limb was normal, but then the power at all the joints in lower limb, ankle, knee, and hip joint, that was grade 0 power, sir. And reflexes, superficial reflexes, plantar reflex was absent, rest other reflexes were intact. And in deep tendon reflexes, knee jerk and ankle jerk were absent, rest all other reflex DTR were present. Then there were no involuntary movements. A sensory examination and cortical sensations were intact. And yes, that's it.
Okay.
The positive findings were there in the motor system examination only.
So now, what is your inference? What does it indicate? Anatomy first anatomy.
Sir, after motor system examination, we know that only isolated motor system is involved. In that, based on the findings, we can say that the findings are corresponding with the low motor neuron involvement. And among that, nerve and muscle involvement is very likely. But in keeping in mind the acute onset of the illness, which is progressing bilaterally symmetrical with no past history, nerve and equal involvement of both distal and proximal muscle. So it is pointing more towards peripheral nerve involvement.
Can I one thing?
Yes, madam.
When you say that there was a difficulty in seating also, he was not able to sit, suggests that there is a paraspinal muscle weakness. And when it is a paraspinal muscle weakness, it must have involved the shoulder and the elbow. So it can never be normal. That is one. Second thing is the first sign, if you don't know anything, whether it is a GBS or not, the first thing what we elicit is grammastic reflex. The grammastic reflex has to be absent. That's the first superficial reflex which is lost. So it can never be present. So whenever you speak the examination, either you should examine thoroughly or you should keep these points in the mind that this goes in a sequence. So there will be no discrepancy in your examination.
Yes, ma'am.
I think good points madam had brought out, and therefore, many times it may happen so that initially we are not clear. Your grammastic reflex may be present, but just on follow-up, suppose if you find that now it has become absent, your other superficial reflex may be present, but that becomes a very important point to make, that this is quite strongly favoring the GBS. Every time all of us know in our clinical medicine that the way in which we are discussing is not distinctly clear in every case. We are finding the difficulty in deciding. But every condition has very specific important clue. And that what Madam has mentioned, that grammastic reflex, particularly superficial, the first to disappear, is a very important point which we should keep in mind. Okay, anything suppose may not be in this patient, but what can happen in the respiratory system? Dr. Apurva?
Sir, if the...
And therefore, how you should keep the watch or monitoring such patients. Very important.
Yes. Sir, if the weakness is progressing further, like it is going more ascending, the respiratory muscles can also get involved and will compromise the breathing efforts. So we have...
clinically, how will you monitor?
Sir, clinically, like we can...
Type of respiration he is asking you.
Yeah.
It will be paralysis of the diaphragm. So what kind of respiration you will get? Weakness essence, it will cause a diaphragmatic paralysis.
Seesaw breathing.
Muscles. So there will be
paradoxical respiration.
Seesaw type of breathing pattern will be seen if diaphragmatic paralysis is there.
These are the intercostal muscles, because these are the external muscles which gets involved. So ultimately, this first comes into the action, that is accessory muscles of respiration. So there will be breathing, and then when there is a failure, you will get the paradoxical breathing.
Okay.
You should monitor the rate, you should monitor the pattern of the muscles involved in the respiration, and that will give a earliest clue that child is going impending respiratory failure. That's what sir wants.
Yes.
Yeah. Is there any very specific clinical test
Single
from which
breath
you can?
count test.
Single breath.
What is single breath count? Yes, Sapura, can you take it this point? I think clinically it is very important point.
So we have to ask the child to take a deep breath, and in 1 minute, how many numbers she can count. So
Yeah.
if it is, I think less than 10 to 15, then it is a poor prognostic sign that the child could be
Okay.
going into
Less than 15.
15.
What it can be for normal person? I think you can count later on for yourself.
30
You
to
have the
40.
idea. Okay. Usually more than 40, even 50 for the good, I will say, compliance of the respiration. But this is the very good, I will say, test. You can see that regarding the phonation, phonation is also going to be affected. Even this weakness is developing. Even with these respiratory muscles, also the phonation will get changed. Even the single breath count you can see. Even the respiration rate you can count. Even you can see the movements of the muscles, even the involuntary accessory muscles. So I think these are the very, very important point for the clinician. Once respiratory paralysis develops, everybody will say. But once patient is with you in your ward and suppose develop this type of the deterioration, you should be able to detect at the earliest so that it can be managed properly. So and respiratory involvement is very common. And therefore, any patient who complains or weakness of shoulders, please keep in mind that the diaphragm is going to be affected because the nerve supply is same, C3, C4. So diaphragm is commonly involved. That I think as a clinician we should keep in mind. Is there any specific involvement of CVS? May not be in our patient, but CVS, I think some of the points we have touched, but anything else?
Yes, sir. Arrhythmias, tachycardia.
Yeah, right. Hypertension.
Hypertension, sir.
Okay. So I think this also will have to just put your statho and keep in mind regarding intensity of the heart sounds or rate and even the rhythm and these problems. And because these carry the very bad prognosis. If you are support detected, you can have some idea also that what the patient is going to develop. I think we will touch this aspect from with Dr. Harshiti at the end. Now, you have any investigations? I think let us take it, investigations, and then we'll learn something advanced from Dr. Harshiti. Isha, you can take, share your PPT with the investigations.
Sir, I have not involved the...
Very good, very good. I think I like this person. The investigations hardly helping us. And on the contrary, nowadays, what the people say, we are learning from these neurologists, that GBS is the clinical diagnosis. I think they say that hardly it requires the confirmation. Probably confirmation from law point of view, yes. Probably confirmation from this insurance point of view, yes. But probably as a clinician, they say that they don't want the confirmation for starting the treatment. So I think now let us learn from Dr. Harshiti very important aspects that what are the very essential features to diagnose the GPS.
Yes.
That is very important. That when these are the very, I would say, cardinal features that it has to fulfill this criteria for diagnosing GPS. And nowadays, I will say GPS is very common neurological condition in general pediatric practice. So I think it is very vital for all of us to be aware of it. And then probably, Harshit, you can take some important aspect of diagnosis and then recent management, I think at least in 5-10 minutes, please.
Yeah. It's basically the name of GBS is basically an acute demyelinating polyradiculoneuropathy. Self is suggestive there is a demyelination and it is acute. So why does the demyelination happens? It's because following the infection. So whenever a patient comes with a history of weakness or inability to move the limbs, the first history which we will ask is, was there any antecedent illness like preceding illness which was suggestive of respiratory tract infection or a common diarrheal illness? If it is diarrheal illness, it must be the Campylobacter jejuni. Or if it is a Campylobacter jejuni, it is likely to have a prolonged course and more severe course. Severe course in the sense that it's not only, but it is a loss of myelin, and there will be a loss, disgeneration of the axons as well. The myelination, you can make it static, and there will be a remyelination, which is a little bit earlier. But when there is an axonal degeneration, the regeneration takes a long time, or there might be the residual deficit. So the etiology preceding illness is very important. Whenever there is an illness, it's bilateral symmetrical weakness. Here, the criteria is, it is not only
sorry, madam, just for interruption to the students. Isha, you mentioned no history of recent vaccination. What was your idea? Dr. Isha?
Yes, sir. Sir, I wanted to rule out whether the patient, since the patient is around the 5 years of age, I wanted to ask whether the patient has been vaccinated recently for polio. And other than that, sir,
suppose if you are thinking for the GBS, then any vaccine related to GBS, that is a direct question.
Sir, meningococcal vaccines of subtype C, then influenza vaccines, so they can cause GBS. Recent.
I think madam will take this point.
Hepatitis vaccine. Usually the hepatitis vaccine takes.
Hepatitis B and the flu vaccine.
So I was just going to think. So ask for the vaccination. Recently, why there is an increase following the post-COVID autoimmune demyelination? That's why we get lots of GBS like illness. But GBS is not only the peripheral nerve illness. It may involve the brain as well.
Yeah.
That there is a diplopia, and I had mentioned there will be the squint. So if there is a diplopia with it's an ophthalmoplegia which is causing a diplopia, and there is a squint which is causing a diplopia. So when there is an ophthalmoplegia which is causing a diplopia, it is a Miller-Fisher syndrome. And there might be the alteration of the sensorium along with the GBS, and that also takes a protracted course, and that condition is known as a encephalitis, right? So there are different 4 types of the GBS, which is a spinal one, there will be a central and the spinal one, and there will be the Miller-Fisher syndrome. In each condition, the treatment differs a little bit, but what we need to think is it's a lower motor neuron type of weakness. There is a hypotonia, areflexia, gradual progression, ascending type of weakness, which may or may not have the involvement of the cranial nerve. And sometimes there could be the altered sensorium. So these are the cardinal points which we'll need to keep in the mind, that there is a progression, hypotonia, and involvement with or without the cranial nerves. If it is only cranial nerves, then it is a weakness only
Miller-Fisher.
Without a peripheral nerve, it's only the weakness of cranial nerves with normal sensorium. The condition is polyneuritis cranialis.
Okay.
Cranial nerves which are involved with the maintenance of normal sensorium. So these are the things which we need to keep in the mind. And once you diagnose that, there might be the pain associated with the GBS. 1, 2. There might be the retention of the urine and the bladder involvement in a patient with the GBS. There are some atypical features which may be. I have seen so many patients with asymmetrical weakness. I have seen a patient with a descending weakness rather than ascending weakness.
Yes.
Be atypical presentations of the GBS, and they are more common now rather than what it was before. And that might be because following the post-COVID, but that's what we are observing. I have seen a patient in the last year, all following the COVID, having a retention of reflexes with hypotonia and loss of muscle power. So there could be some atypical features associated with the GBS. Second thing is the treatment. Treatment, everyone knows you give an...
I think just before that, from the exam point of view, what is the importance of Csf examination? And
when you should take a CSF.
And what time it should be done?
Yes, when should you?
Yes. 2nd to 3rd week of illness.
Why?
Albuminocytological dissociation.
Dissociation. So there will be the nerve muscle thickening, edema, which will release the protein. That's why you get an albuminocytology, because there is no infection.
Yes.
You get an albuminocytological dissociation to be taken in the 2nd week of illness.
I think now can you take some part of management, which is very important.
Yeah, the management is very obvious. we should start giving something which is making a demyelination at hold, or that will help in the remyelination. And for that, you have lots of immunomodifiers, and that's why we give immunoglobulins. So previously we were giving 250 unit per kg for 5 days, but it's long course. So now we give 1 gram per kg for 2 days, and we complete 2 gram per kg in 2 days, so that will hold the progression. The main idea of giving an IVIG is to hold the progression, but not to reverse the progression. So if there is a fast, rapidly progressive GBS, especially when there is involvement of the respiratory system and autonomic system, you need to give IVIG at an urgent basis. Following an IVIG, it may happen that patient may not regain. So what you need to see once you give an IVIG, that's very important, because that's what clinically what we see. Following IVIG, it may happen that patient may have a mild progression of weakness. That's very important. So you will feel that patient is not responding to your treatment. So it's not so. What you need to see is it's a mild progression, 1. 2, respiratory system involvement is at hold. It's not progressive. That's very important, because our idea is to prevent the progression. So the respiration and the impending respiratory failure, which was there, or there is a respiratory failure, does not need a more FiO2 and all. So that is the criteria. If after 1 month there is a progression of weakness, and there is a static weakness, there is no improvement, or there is a deterioration, you can repeat the dose of IVIG after 4 weeks. If end of 9 months, which is a time when there is a regeneration of the myelin, that is known as a Swan, I've forgotten the name anyway. So, so if there is no regeneration, then you can stem, or there is a reappearance of the weakness, then they turn out to be a patient of chronic GBS or a chronic CIDP, that is chronic inflammatory demyelinating polyneuropathy, where you need either a repeat course of GBS, or you need a repeated course of rituximab or methotrexate, immunomodifiers. There was another query of starting a methylprednisolone, whether to start or not in a patient with GBS, but there are, except one study, most of the studies suggest that it deteriorates. So you should not give a methylprednisolone.
I think, is it so, as Madam said, that nowadays probably there is no place to the steroids in management of GBS. Most of the times, the only thing that when there is a severe root pain, and that pain is severe, to probably help for the inflammation point of view, you may give the steroids in that condition, but otherwise GBS.
But nowadays, I forgot to tell you, nowadays we use a gabapentin for neuropathic pain rather than.
Achha, right.
We use a gabapentin.
Right.
It gives a good result.
Is there any importance of the plasma paresis in these
plasma
patients?
paresis, plasma exchanges.
And then when it is to be done?
Yes, it does help. It helps in removal. But when to take it? Like you have IG and you want a patient is not improving and there is a deterioration and patient is less than a week and you cannot give another dose of IVIG. You let the IVIG to wait for a week, and then you can go for the plasma exchanges.
Is it so, Arshad, when some people say that if you do the plasma paresis after this immunoglobulin, then probably you will remove it and may not be help, and therefore some people prefer that plasma paresis should be first.
Both the mechanisms are different. The plasma paresis is to remove the antibodies. So if you remove the antibodies, whatever the immunoglobulins which you are given, the antibodies from the outside will be removed. Will be to go for the plasma phoresis.
You are muted. Dr. Arshiti, you are muted. Unmute yourself.
Sorry.
Yes.
So the basic thing is both mechanisms are different. Either you remove the antibodies or you give an antibodies from the outside. So if you are removing it, then you should have the plasma phoresis first, followed by IVIG. Or if you have given the IVIG, you wait for 1 week or 10 days and go for the plasma exchanges, because the antibodies remain in circulation for 30 days. The same principle is applied as in the vaccination.
Thank you. I think it's a time for us to end over here. I'm sure that this was an excellent discussion. First, I wish to appreciate Dr. Yesha for selection of the very good case. Even she provided lot many informations in the history. Probably she must have gone in the details. So Dr. Yesha, best compliments for her presentation, and Dr. Apurva for her presence, and you are participating actively in the discussion. I'm sure that in a long way it helps a lot in our learning. And of course, presence of Dr. Harshit Shah has made the difference. We can understand that how much even the involvement and interactions, and I will say very important points, learning points for all of us in the particular case. Thank you very much, madam. I'm sure that even in the future also we'll
Sir, I am back into the examination room. I feel so with you.
Thank you very much.
Sir, I would like to thank you all for this opportunity.
And we should express a word of gratitude to the office bearers of Gujarat State Branch for providing this platform, and of course Dr. Nehal, who's taking lots of the pain for arranging the whole case, which probably we are enjoying for 2 hours. Thank you very much. Over to you, Dr. Nehal.
Yeah, thank you very much, sir. It was a very nice discussion, and I must congratulate Kesha. She prepared the case in a very short notice, and Apurva joined. She was not knowing what the case is, as she is coming from even the different state, not even from the Gujarat. So still, she tried her best to give support to Yesha, and I thank Harshruti madam. Again, I was feeling like I'm giving exam, and I'm taken by the two teachers, as sir was already my external examiner. I was giving the exam. So lots of information.
With him, we always feel so.
I think last point, let me, for the sake of the students, the history part of the GPS. You know, previously it was called as Landry's post-infectious ascending polyneuritis. Landry was the first person to give these ideas. Later on, for some time, it was missed in the history, and then Gullian and Barry, I think both of them. I remember probably third person was there also there in the history. Later on, he left these neurologies, and therefore the name remained with the Gullian-Barre syndrome, GBS. So I think, you know, it's interesting to know even that how the name is derived, but very truly, it's a post-infectious ascending polyneuritis, and I think that condition name itself, this common presentation is like that. I'm sure that really in this session, all of us learned a lot. At least personally, I feel that many points we noted. Thank you very much, all of you. And next Saturday again, we'll come with some new case.
Yes.
Thank you very much.
Thank you, sir.
Bye.
Thank you,
Bye.
sir.
Bye. Thank you.
Ma'am, then shall I conclude the session here?
Yes.
Yes.
Thank you so much, everyone.